My guest today is Dr. Ruben De Groote. Ruben and I met in 2019 when we were developing and validating the metrics for the robot-assisted radical prostatectomy. Ruben's a consultant urologist at AZORG in Aalst in Belgium, and his practice primarily consists of robotic surgical procedures, mostly oncological. He is the CEO of 4Health and his very successful digital platform, learning platform SurgeQuest. Ruben recently completed his PhD on the development and evaluation of a proficiency-based progression robotic surgical training program for 3 surgical disciplines. And proficiency-based progression and training will form an important part of our conversation today. You're very welcome, Ruben, to Show Me the Evidence. Ruben, what are the fundamental limitations of current surgical education models that make a new approach to teaching and learning operative skills not just desirable, but necessary? What's your views on that?
It's not an easy question to answer, but then again, it is because the problem is very, very clear. Surgical education, as it was in the past, and as it was until very, very recently, is not the same anymore as it is now and as it will be in the near future. The problem is that the way how surgical residents were trained in the past is not possible anymore to get to the same stage and to the same level of expertise by the end of residency training. So before, about 100 years ago, surgical residents started training using the Halstedian model, the apprenticeship model, the see one, do one, teach one model, as they say, and everything stands or falls by exposure. So in the ideal way, surgical residents, they are being trained using surgical exposure. And so this is, if you were in a good training center, this was actually applied stepwise. So you first got exposure by observing cases in the OR, then you might go a little bit closer. You actually be sterile at the operating table to see the procedure a little bit better. Again, better exposure. Then probably when you get a little bit more experienced and if you make some steps on the ladder, you can increase your exposure by doing some basic steps of the procedure. And so you evolve stepwise, gradually in your surgical exposure, where you, at the end of your training, you were supposed to be able to do independently complex steps of surgical procedures and basically also full surgical procedures independently. Now, over the last 15, 20 years, the circumstances of surgical training have changed significantly. There are different external factors which make that surgical exposure in the OR has diminished significantly. The residents nowadays, they have to attend way more bureaucracy. And this is not a long time. When I was a surgical resident, and this is not that long ago, I was able to actually do all my bureaucracy before 10 o'clock in the morning. And then I went to the OR to get the exposure in the OR that I wanted to have. Nowadays, surgical residents, even if they are very ambitious and they do their best, they have to spend at least half a day at the ward to actually deal with all the bureaucracy before they can get into the OR. So that's problem number one. Problem number two is that there is a restriction on working hours. So surgical departments are actually being punished legally if they allow their residents to work more than 60 hours a week on average. So this makes that they get, again, less exposure in the OR, and so that they're actually getting less trained according to the training model. And so this is a vicious circle where they are in because they get less exposure. So by the end of their training, because we are still in a time-based curriculum where they actually get 5 or 6 years of surgical training and then they have to be finished, by the end of their 5 or 6 years, they are deemed to be independently. But because of the lack of exposure, which is still the cornerstone of surgical training, we know based on good publications that almost 1 out of 3 surgical residents are not independently ready anymore to do surgical practice. And this is, of course, a hazard for patient safety. Now, luckily, most of the surgical residents are quite smart. they realize that they are not ready. So what they do, they don't go into independent practice, but they go into different hospitals to do fellowships to actually get to the level that they want to have before doing independent practice. And so these fellowships, and I did a fellowship myself, it was actually to super specialize myself into surgical robotics because I was already able to independently do a surgical procedure at that time. They are now being transformed into sort of an extension of surgical residency to get independent in their practice. And so this again leads to less exposure of the residents who are still there. So this is a vicious circle, and this is really, really going fast, that the exposure is diminished significantly. And so the cornerstone of the time-based curriculum, this exposure is vanishing very fastly. And so there is probably no space anymore. It's not justifiable anymore to actually go with this way of surgical training in the future.
Can I ask you a naive question? Where did all this bureaucracy come from?
Well, I mean, I don't know. Well, I do know. I have been a resident myself, and I have seen it changing. This is a change in medicine in general. It's not only in surgical medicine. This is a phenomenon where people don't want to take responsibility anymore. Before, when I was a resident, nurses were allowed to accept verbal orders to give medications, for instance. Nowadays, they are not allowed to do that anymore because they don't want to take the risk. They don't want to take the responsibility anymore. And it's not their fault. They're not to blame, but it's actually the hospital managements who forced them to not do this, because if they do, they're getting punished. And so the consequence is that for the most simple task, even prescribing paracetamol, for instance, there needs to be a written order. And so this extremely increases the bureaucratic burden for everyone, not only for the residents, but also for the nurses. And this is good until a certain extent, because of course, before there was no written orders whatsoever. So you need to have some, standardization. But nowadays we are living in a time that the smallest thing you do needs to be written down. And this is actually backlashing extremely.
Yeah. So what you're saying is more process-driven practices imposed on surgical trainees, which is actually impeding on their time. And you describe it as exposure to the operating room and what's required and so on. Are these problems the same or worse for robotic surgical training?
Well, I think that robotic surgical training is quite special because it has pros and cons. Robotic surgery is a challenge for surgical training. Why? Because you have to combine two different aspects. You have to combine quite challenging procedures. This can be procedures of any kind, but most of the procedures that you do robotically, they actually have several steps. They have different possible errors which can occur. So they are quite complex and challenging procedures. So these procedures by themselves is not that easy to learn. But then again, you also have the technological part, which needs to be combined. So you have to master the technology, of course, before you can actually apply the added value of this technology for the sake of your procedure. So this is a challenge on its own. I think, however, that robotic surgery is a really good thing to apply new training methodologies on, because where it differs from open surgery or pure laparoscopy, for instance, is that robotic surgery, you have a computer in between of your eyes and the patient. So this allows to store your video files, to store all your surgical data. And this allows you to actually go back into your surgical procedure, to review it, to give formative feedback to your residents, and to also measure some kinematics, which can make a difference and which can actually objectify your surgical procedure. So I think that robotics is a really, really good tool to measure surgical quality and to in order to improve it.
Oh, I agree with you about robotics, but is observing somebody using the robot and doing the procedure, is that sufficient? Because, I mean, what you were saying previously was that it was in surgical training, it was exposure. And to be quite frank with you, I'm not convinced that exposure on its own is sufficient. I think you're going to need some sort of structured and metricized training. And there was a structure in the Halstedian approach. I mean, but he or his colleagues imposed the structure. And for robotics, I think you absolutely need that structure. Would you agree, or?
Yes, absolutely. I think this is the case for every technology, whether it's robotics or where you implant cardiac pacemaker device, for instance. Every technology stands or falls with the use of it. Still, we are living at a time where the added value of robotics is being disputed because some people actually don't use it as it should be used. So, of course, exposure is not enough. It's how you do it. In the time when Halstead at Johns Hopkins actually developed the training methodology of the see one, do one, teach one, he was like the chef of a very famous restaurant. Let's say there were a few hospitals very well known for surgical training where everyone wanted to go. It's like you had a few very well-known restaurants with very good chefs, and actually they made the laws. They made their own recipes and they made it happen. They took care of their residents, and they made a good training curriculum. But it was not universal. There was no universal cooking recipe which was applicable for every single center. And so I think that we're coming now in an era where we need much more standardization of surgical training. You cannot only rely on being in a very good surgical training center to get proper surgical training. There needs to be benchmarking on surgical quality, on surgical training. Not every single center where they perform surgery should be allowed to probably do surgical training unless they have proven to reach certain benchmarks of quality of surgical training. So this is train the trainer, of course, but also the methodology which should be used in those training centers should be universal and should be driven by science and by scientific evidence, rather than only to rely on the expertise and the experience of the trainer who is actually present in that training center.
Mm. So the apprenticeship model has served certainly surgery and procedure-based medicine for more than a century now. So I'm getting the impression that you think that it's more than simply the problems that that surgical training is facing. It's more than simply a reduction in workers. It's more probably than a problem simply of exposure. So do you think there are more systematic issues that need to be addressed in not just surgery, but in procedure-based medicine in terms of a training paradigm?
Yeah, absolutely. So exposure is one thing, but during my residency and during my fellowship, I was lucky enough to see different people, different ways of surgery. And this, of course, can be an added value because there are different ways to skin a cat, and you can get to the same surgical outcome in different ways. So learning different ways how to do a surgical procedure is definitely an added value. But what I also have seen, and this is a downside of not having standardized surgical training curricula, is that different people train in different ways, and this can be extreme. If you're unlucky and if you're with a trainer who actually is not interested in giving surgical training, you won't get any surgical training whatsoever. And this can be purely determined by the fact that this person doesn't like you, for instance, or he doesn't like he doesn't like the fact that, for instance, female surgeons are getting into surgical training more and more. This is something that we see, that female surgeons often complain about the fact that they get less training just because they are females. And so you're very much depending on the goodwill of your surgical trainer. What I've seen during my fellowship, and we were six fellows, and there were 9 different consultants doing all radical prostatectomy. And one week you got trained by one consultant, the other week you got trained by another consultant. And by the end of your week, when you actually appreciated certain ways of how to do that part of the procedure, you went to the other consultant, and he said, like, "What are you doing? You're doing completely wrong. You should do it like this." So this is crazy for me. I mean, there are different ways, but it's not that one way is wrong and the other way is only right. So there is a complete lack of standardization. And this was not in a very small hospital. This was in the biggest UK cancer center where I did my fellowship. So the lack of standardization is a real is a real problem still nowadays, and it's only increasing, in my opinion. For me, what is also one of the biggest issues is that nowadays surgical safety more and more is being compromised. People are not ready anymore at the end of their training to independently operate on patients. And patients are not only being used as training models according to the apprenticeship model in the beginning of training, but they're actually, and this is more dangerous, they're being used as still training models of consultants who are not ready anymore because they didn't get trained well. And so the patient is the victim because they will get worse outcomes because of the lack of training of this person. And so I think this is something that needs to be addressed legally. There needs to be benchmarking of surgical quality, not only at the end of surgical training, but also during surgical training, at the beginning of surgical training, who has who has enough talent. This can be measured to be allowed to get into surgical training. So benchmarking, I think, is everything, and this actually defines how I would see it, because we are still now in a time-based curriculum. Everyone does 5 or 6 years of surgical training, depending on the specialty where they're in. And at the end, they actually get a thumbs up or a thumbs down. Mostly it's a thumbs up, whether they're good enough to start or not. Very, very subjective. But we know that most of the people are not ready anymore. And so you need to move away from a time-based curriculum to a more competency-based curriculum, where some people probably will not even need 4 or 5 years to get completely proficient at certain procedures. Then again, some people will need more, will need 7 or 8 years to get to the same level of to the same level of proficiency, and that's okay. Not everyone can be as talented as the others, but at least you will have safe surgeons when they start.
Yeah, I totally agree with you, Ruben. At Yale, when we did the VR to OR study, there was one of the surgical residents, she took the longest to demonstrate the proficiency benchmark. And that was fine because it was on a simulation. But when she got to the proficiency benchmark, she performed the best in the operating room. And I think trainees and residents, they need that space, not just to learn the task, but also to hone their skills so that they can perform consistently.
Mhm.
But I suppose this is an unfair question. Who should be doing that? Who should be policing those standards? Who should be imposing those standards? Because industry worries about this as well. Industry sees individuals, surgeons, cardiologists, radiologists, using their devices, and they know they're not ready, but they can't say to them, "You can't do that." And they would like to push it back to academic training centres or places like Aalst to say, okay, you tell us when this person is ready. Everybody's looking around for somebody else, to impose or police those standards. I mean, the European Robotic Urological Society, I think they're one of the leading professional or scientific societies in the world, and they seem to have grasped that nettle with their fellowships. And I suppose the question is, who do you think should be setting those standards, policing those standards, and advising the residents you're not ready to go?
Well, I think there are different instances. So you have setting the standards needs to be done by scientific research. This cannot just be the opinion of one or a group of people. This should be based on scientific research. I think PBP is a very, very good example of how you set the bar, how you set the benchmark. This is not something which is just, opinionated or is plucked out of the air. This is actually the result of a rigorous scientific process to get to a very exact description of a surgical procedure with a very exact definition of steps, errors, which actually represent the ideal way of how to do a certain surgical procedure. So I think that it's scientific work done by scientific institutions, scientific societies, which need to set the benchmark. I don't think that the scientific societies should be in charge to make these benchmarks mandatory. I think that this should be a work for the authorities. If you see, I'm a medical doctor. I am allowed for prescribing medication. I was allowed to do this after 7 years of medical studies. I got a diploma, and since I got the diploma, I got also the fact that I could prescribe medication. I think that there should be a sort of a parallel. You have credentialing for medicine. You you want to go to more credentialing on a lower level, micro credentialing for certain technologies, certain surgical procedures. It's not because you're a urologist that all of a sudden, and you get a diploma to do that, that all of a sudden you're also a good robotic surgeon. This is just, this is maybe not implemented in your surgical training, and you should be able to prove that you can use this technology for the benefit of the patient. So I think that the authorities, the and this of course is government, universities, I think that should be able to control who can do what, and this should be driven by scientific research by the scientific societies.
Yeah, I
Industry,
think
I think industry, just to conclude, I don't think that industry should have a large role in that. Let me give you an example. Industry has a conflict of interest. Industry is driven by sales. They want to sell systems. If you have a good industrial partner, they will be willing to that their systems are being used properly. Then again, most of those commercial institutions, these companies, they don't really care as long as they have sold their system. I'll give you an example. I'm asked from time to time to do proctoring, and this can be, and most of the times this is proctoring for people who are extremely novice. Now, for me, I really, really don't like to do that, because you come into an OR which you don't know. There is a person who is assumed to do the whole procedure under your supervision, and you are actually not allowed or very limited to take over. So this goes completely against proficiency-based progression training, benchmarking, measuring quality, and this is endorsed by industry and maintained by industry, because you're getting paid to do that as a proctor by industry. And I think I really don't like to do that proctoring, that kind of proctoring, when I train my own fellows according to the PBP principles, and they will never be allowed to do a nurse pair, for instance, when they are not able to do properly a bladder neck dissection, or to do less complex parts of the radical prostatectomy. But as a proctor, paid by the companies, you're being forced to actually guide someone very difficultly through the bladder drop. And in the same procedure, you have to guide this person through the nurse pair, which is far more complex. So this goes completely against principles of benchmarking and quality assured training.
yeah, frequently devices fail in the marketplace, and it's really nothing to do with the device.
Yeah.
It's that the individuals that are using the device are not prepared or not ready to use the device. And I would have thought industry would have cottoned on to that quite some time ago. Can I just digress slightly? Okay, you've done a fair bit of work on teaching multidisciplinary surgical trainees, and the data that you've published seems to offer a compelling reason for reimagining surgical training. So, why is this shift in approach now an imperative for healthcare education more broadly, and not just simply for surgery?
Yeah. So we did a publication where we did a randomized controlled trial where we compared two training methodologies. We had the apprenticeship model compared to the proficiency-based progression methodology, and it was very briefly summarized. It was clear that the PBP methodology group, they outperformed the traditional trained group, the apprenticeship model, significantly. So 67% of PBP trainees were proficient by the end of the day versus 17% of the apprenticeship model trainees. Now, we deliberately did this RCT as a multi-specialty trial. So we included urologists, general surgeons, and gynecologists. And this was driven by the fact that there is a very strong opinion by certain people in surgical medicine that some surgical specialties are less skilled than others and actually have way more complications. So I am not saying that certain surgical specialties are more skilled than others, because I think this is definitely the case. But the question is why. Sometimes it's said like it's because you're that sort of surgical specialty, you're born with less skills. What we shown in the Provisa trial, this RCT, is that this was not the case. The three specialties, when they did their first vesicourethral anastomosis, so the baseline assessment of that very specific task, they all performed equally well or badly. They were all not very good. By the end of surgical training, they all performed as well as each other, the three surgical specialties. The only difference was that all the surgical trainees, all specialties in the PBP group outperformed the apprenticeship model trainees in every single specialty. So the conclusion there is, and these were all robotic naive trainees, they were first or second year. The conclusion is that it was not their surgical specialty which was predicting their surgical skill set at the end of training. It was actually the methodology itself. And so what we very often lack in training of surgical specialties is that people are being trained only within that surgical specialties. And so, of course, there are some habits. Surgical medicine is built on habits and habits which are actually being maintained over generations. The way how you close an abdomen, for instance, can be different if you're a gynecologist or if you're a general surgeon. And this is, this is being maintained because there is very little crossover between specialties during surgical training. Probably it's differences in surgical training methodologies and surgical training between different specialties which determine the difference in skills at the end. I was lucky enough during my first year of urology training, I did a lot of cardiovascular surgery, a lot of thoracic surgery. I did a lot of intensive care unit work, and I really, really benefit from it because cardiovascular surgery has learned me not skills per se. I don't have to do vascular anastomosis or very, very little, of course, as a urologist. But what I learned is the appreciation for standardization, need for systematics, need for teamwork, which is so very significant, important in cardiovascular surgery, for instance. And these are principles which I still use being a urologist. And this is something which I very often don't see with colleagues because they haven't been trained in these specialties. So I think that it's a plea to try to build in crossovers in surgical training curricula to learn from different specialties and to actually get less differences in surgical skills between specialties.
Yeah, I mean, my interpretation of that published study was that it was the systematic, scientific, quantifiable, evidence-based approach that actually led to the PVP group, the gynecologists, the general surgery, and the urologists, to them performing better. So it really goes back to more than just exposure. I think it's a systematic approach to training. So if you want to be that systematic, you probably need to quantify. So to what extent is it possible to reliably quantify intraoperative surgical performance? And what do you think are the key methodological and practical challenges involved, particularly in developing validated metrics?
Yeah. So I'll give you an example to start with. So I was asked to be part of a study to assess the surgical skills of more than 100 senior surgical trainees on a vascular anastomosis on a kidney transplant model. And so I was very enthusiastic, and the first 5 or 10 or 15 videos, each they took about 10-15 minutes. I watched them completely. And so I was asked to use the Likert scale based scoring tool, the GEARS score. It's an abbreviation for the Global Evaluative Assessment of Robotic Skills. And so I was asked to use these Likert scales based tool to assess the surgical performance. And so the first couple of videos, I watched them completely because I wanted to see the skills. Now, very quickly, I noticed that my scoring of a certain procedure really depended on the procedure which I saw before, because I was continually comparing people with each other. And so probably the first video that I scored, if I gave a 3 out of 5 on a certain skill set, that might not have been the same as a 3 out of 5 as I had given after 10 videos. So this means that there is a very, very subjective way of scoring certain domains of surgical skills. So that's one of the problem. And so this gears tool still represents the most used way of scoring robotic surgical skills in surgical medicine. And so the subjectiveness, that's one. Now I'm speaking about subjectiveness, just comparing videos to each other. Now subjectiveness can go to an extent way further. The subjective feeling of a trainer towards a trainee when he is not blinded makes a big difference. When a trainer doesn't like the trainee for different reasons, he will probably score less good than someone that he likes or she likes. And this cannot be controlled. There is no way to say you scored this person lower because you don't like him. He can just claim I scored it because I think this is the proper score. So subjectiveness, that's a real problem of these Likert scores. Then of course that's limitation number one. Limitation number two is that you have a big issue of inter-reader disagreements. What is a 3 out of 5 on a certain domain for me, it is not a 3 out of 5 on that very same domain for the very same procedure for another person. We know that if you want to have a diagnostic tool to be valid, to assess surgical quality according to the standard of psychology, you need to have an inter-reader agreement between two independent reviewers of 80% or higher. We know that the GEARS scores lower. In our study, we only had 30% of agreement between two readers of the same surgical procedure. And so actually by default, this makes this tool not valid anymore to be used to assess surgical quality. So inter-reader disagreements, that's a second limitation. And then third, it's an advantage, but in my opinion, mainly a disadvantage. This is very, very generic. This GEARS score, for instance, can be applied for any given surgical robotic procedure, whether it's basic, whether it's complex, whether it's very advanced. It's very, very generic. And so if I go back to the example which I gave at the beginning of this explanation, I had to do 100. The first 10, 15, I watched them completely. The last 80, I watched maybe 2 minutes of every video, because that for me was enough to actually make an assessment and make a score. And there was no way how the people who were responsible for the study could correct me and say, like, did you watch the whole video? So I said, yeah, maybe I've done it. So there is no, so this is very unfair, in my opinion, to the ones who are actually doing the performance, because it's your own personal opinion, and this is eminence-based medicine, which actually you make it more important than scientific research and scientific evidence, which is the core basis of evidence-based medicine. So I have significant problems with these Likert scale-based tools. So, and I definitely think that there is a way forward using metrics, because metrics are procedure-specific.
You mean binary metrics?
Binary metrics are procedural specific, so you can only use a certain metrics for a certain procedure. These are not applicable for other procedures, and this of course makes it less generic, makes it of course also more laborious, because you are forced to watch the whole surgical procedure in order to make an assessment. But this is binary. You can only score what you see. This is 0 or 1. A step occurred according to a certain definition, and an error was done or wasn't done according to a very specific definition. So there is no way to cheat. And this is not your opinion. You're just following the metrics. And these metrics are not made by you, by your personal opinion. This was the result of a scientific research, of evidence-based medicine. And so you're just applying the results of evidence-based medicine to that surgical procedure. So actually, metrics and PBP rules out the personal opinion of a certain assessor, a certain surgical trainer, of the performance of a surgical trainee. And so this makes it fair and very transparent, because you know exactly what they did, and you know, more important, you know exactly what they actually did wrong. And so if you go back into the metrics after the procedure, you can go to the surgical trainees and you can say, like, here, and here, you made an error. So here you have to pay attention next time in order to avoid that error. And so like this, they will improve very, very fast, and they will improve their outcome very, very significantly.
So what you're saying is the binary metrics are not just for assessment, they're actually for giving the trainee feedback on their performance. And I'm assuming that the advice is pretty explicit. It's not
Yes.
like a Likert scale.
So until very recently, in the hospital where I work in Aalst in Belgium, we have a lot of fellows there, and so every Thursday, by the end of the day, after the robotic procedures, we come together as a group, and every time one or two fellows are being asked to show a part of the procedure which they actually did themselves. And so we have a very big screen. We make it a split screen, so you have the surgical procedure on one side of the screen, and you have the dedicated, validated operative metrics of radical prostatectomy on the other side of the screen. I'm just there as a facilitator. I am just there to translate these metrics to those procedures. And so we go over these procedures, and I say, like, this step, according to the metrics, you performed well, or you didn't perform it. You did it, or you didn't do it. And here, and here, you actually made an error. And so this is, of course, extremely valuable for these trainees because they get formative feedback. You're not bashing on them. You're just pointing it out. So this is not my subjective feeling. It's just me translating metrics to a certain procedure. But also for people who are sitting around the table, they hear this formative feedback and they learn from it. And this is way more valuable than me just saying, this is good or this is not good. Because you don't know why it's not good. You have to say, you have to point out the errors. And so for me, this is the clinical translation of how PPP should be done in procedural-based medicine in the operating theater. Because you're not as important as you think. Eminence-based medicine is ruled by people who have a God complex. They think that their way of doing a procedure every time is the best, but PPP rules it out. People actually, we know this based again on big studies. We know that people who are deemed by scientific societies, and not at least by themselves, as being expert surgeons, high volume surgeons, very, very good, they actually, when you score them based on metrics, and we know that this is associated with their outcomes, they score sometimes extremely poorly. And so there is no way to hide anymore. You're just being assessed fairly. And you cannot blame the one who is scoring you because it's not this person's fault that you're scoring badly. It's just your own performance. And with Likert scale tools, you can blame the person who actually used the tool because it's his opinion against yours.
Yeah. So do you think is proficiency-based progression a better way to train surgical and procedural skills?
Yes, absolutely. So there's no doubt. And again, this is not my opinion. We just have to go according to the principles of evidence-based medicine. When a methodology shows that you have, when you apply it and you then compare it to the traditional training, to the apprenticeship model, that you have on average a 60% reduction of intraoperative, objectively assessed performance errors, that you just have to accept as a scientific society that this methodology is better. And this is not only errors, this is also being translated into better outcomes. We know based on studies that if you do a certain surgical procedures with a lower amount of surgical errors, that your outcome will be better. And this is not dependent by the surgeon, because we also know that it's not because you're deemed to be a good surgeon that your outcome always will be good. If you have a bad day, if you have been drinking too much the day before, and if you make a lot of errors during that procedure, your outcome will be bad. But if you push the limit and if you try to do your best and if you avoid errors, then your outcome will be good. So, and I think this is something which is really shocking, because people, still surgical medicine goes with the big names. People are actually thought to be good surgeons, whether they have slept a lot, whether they didn't sleep well the night before. It is all about surgical quality. And of course, big names most probably have good performance and make low errors. But this is not automatically like this. Sometimes you can be a big name for other reasons. And so PBP rules us out. It's transparent and it's fair.
Yeah. So at what point in your career, your young career, did you come to this conclusion? And was learning PvP and the whole metricized approach, I mean, did that impact on you at all? Because I remember the first time I met you, we were working on the scoring of the metrics for the radical prostatectomy, robotic prostatectomy with nerve sparing. And now you have very clear views. You seem to have thought them through. So when did you come to this conclusion, and why? I'm curious.
Yeah. So just as for my background, before I knew you and the principles of PvP training, I was trained in a good way. I had a good mentor, a very expert surgeon who operated in a very, very systematic way. I learned a lot. I had a huge amount of exposure. So I think according to the apprenticeship model, I probably had one of the best trainings possible. Just to give you an idea of where I was at the moment that I learned to know PvP. I was actually very, very happy with the way I was trained so far. Then I learned to know the principles of PvP, and in the beginning, for me, this was a little bit theoretical principles. I got the story, but I was still a little bit searching on how to clinically apply these principles. And there are two distinct moments during my surgical career so far that I noticed PvP works. It's not only a theoretical principle. The first time was when I was involved in the construct validity study of the radical prostatectomy metrics, where I had to watch a lot of surgical videos of novices, but also videos of very experts, and I had to apply these metrics to these videos in order to score them. So by doing that, I really learned these metrics by heart. I exactly knew the procedure divided up into different phases, different steps, and all the different errors at the different steps. And so since then, for me, there is no way back anymore. I cannot imagine doing or teaching a procedure not according to these principles because there is no alternative. The metrics are the only very, very good validated procedural specific cooking recipe for this specific procedure. Before, it was only the non-written personal opinion of certain people who actually learned you how to do a procedure. And now all of a sudden I have this gold in my hand, this validated piece of work, which actually explained the ideal way of how to do this procedure. So then I realized this is something which is a hold on for me as a surgeon. I can always go back to that and I can actually measure my own performance. I can actually see how I improve. I can actually see which kind of errors I made and how I can avoid them. So there is no way back anymore once you go into the PvP way of training. And then the second moment was not applied to myself, but I always had the feeling that if I would apply these metrics to someone else, would they also catch the message? And this was during the Provisa trial, the RCT that we have done in ORC Academy. The very first minutes that we trained people in the PPP group according to those specific metrics, I knew it works. Because if you give me two videos, one video of someone who is PPP trained according to metrics, and one video who is not PPP trained according to the apprenticeship model, within 30 seconds, blinded, I can tell you which one is the video. Because PPP trained surgical trainees, they think when they operate because they think in order how to avoid errors. So they move very smoothly, thoughtfully, slowly, you would say. But every move they do is efficient, and every move they do is there to avoid errors. And so they look slow, but they are fast because they make no unnecessary steps and they make far less errors. And they do all the steps as they would do in the apprenticeship model. In the apprenticeship model, they make errors. And the thing is that they don't know they make these errors because nobody pointed them out. And they repeatedly make these errors again and again and again. And they will improve slowly, steadily, and they will, in the end, also avoid errors because they get just more fluent in the procedure. But, but if no one points out the errors, you will not avoid them automatically immediately. And so for me, this was very clear that if you apply these PPP metrics, you will get your trainee to a surgical level so much faster than if you would only use your personal opinion.
Yeah. And so is PPP only for residents, or do you think it might be for the consultants or attendings as well?
No, absolutely. This can be applied for everyone. This can be applied, of course, for surgical residents. This can be applied in the beginning of the surgical learning curve for very basic steps. This can be for very complex steps. This can be for advanced surgical procedures, for novice consultants, even for experienced consultants. So then this can be for nurses. This can be for everyone. So absolutely.
Yeah. Yeah. So do you think it's only for technical skills, or do you think it's for other aspects of learning?
No, I mean, PPP is all about standardization and making things systematic and efficient. I think there is a very good paper written by Dorothy Breen, and this was it was also an RCT. It was actually the comparison of using PPP methodology versus the standard way of doing it on handover of patient communication using the ISBAR system. This is done standardly on ICU. It was shown that if you applied PPP, if you applied metrics to hand over communication, to hand over information on patients, that you just do this way more efficiently, that you don't hand over information twice, that you don't hand over wrong or unuseful information. You just are better in your handover, and it just makes sense, you know.
Yeah. Yeah, I mean, the basis of proficiency-based progression is that you start with somebody that genuinely knows how to do the job, and you work out what is it they do, what is it they don't do, and you don't start with just one person. You start with three experts. You take it to a group of their peers, and so what you end up with is what you said. You have a standardized recipe for what you do and what you don't do, and it's my experience as well that I totally agree with you that it drives the learning curve and accelerates it enormously because there's no ambiguity. I mean, we started off, we talked a few minutes ago about, the way that you get exposure. This is not just exposure, it's instruction. And I think that in part drives the whole process. So what changes would you like to see introduced into procedure-based medicine training? Because, I mean, I know you're heavily involved in training, not just training, but proctoring. So what changes would you like to see?
So if we, as a surgical community, which we just continue the way we are doing it now, neglecting actually all the changing circumstances, as we have discussed, bureaucratic circumstances, legal circumstances, financial circumstances, working hours, then we just would be stupid because we are actually driving a whole generation of surgical trainees into independent surgical practice not being ready, and we expose patients to surgical hazards. It's actually allowing a group of pilots who are in training to fly jumbo jets without actually having to shown that they are proficient at a simulator. So I think that it's time to change. And this, again, this is not only my opinion. Already years ago, there was a proposal made by the Institute of Medicine in the United States, who are responsible for surgical training, that the time has come to move away from the time-based surgical training towards competency-based surgical training, where benchmarking and measuring surgical quality based on quantitative, metrics-based analysis is the cornerstone. And so allow me to say that I'm still so frustrated when I see that institutions like universities still very strongly hold on to institutionalized way of surgical training. It hasn't changed. When we say that things are changing, allow me to say at very limited amount of places. More than 90% of the surgical training centers still do training the same way as they did 100 years ago. And as long as there is no directive from a government where you make it mandatory, if there would be, for instance, European guidelines endorsed by the European Association of Urology, for instance, which almost make it mandatory to train according to certain principles, then you will change something. But if you just allow people to choose the way they want to do it, they will just continue the way they do it. And what we need, in my opinion, is strong leaders, leaders who actually are open, who are unbiased, who are open for the results of scientifically endorsed papers, who show that certain methodologies just outperform other methodologies, and are strong enough to force other people to apply them.
Yeah.
And you need people who are willing to do that, and you need people who are willing to avoid making compromises there.
Yeah, I totally agree with you. I was in Melbourne a couple of years ago, and somebody asked me, "Okay, Tony, you've all this evidence about the effectiveness of proficiency-based progression simulation training. Why has it not been more widely adopted?" And the words were out of my mouth before I realized. And what I said was a failure of leadership. And so I totally agree with you. But I mean, this is a methodology's been around for a quarter of a century now. And
Why was Halstad able to impose certain way of surgical training to a whole surgical community? See one, do one, teach one was invented by him and was the standard of care for more than 100 years. This guy was a very strong leader. He has a very big name. He made a lot of revolutions in surgical medicine, and so he was actually able, with his name and with his power, to change something in surgical training. But now circumstances have forced surgical community to move away from that paradigm, and we need to go into someone else. And I think there is a clear answer which one to choose.
yeah, I mean, one of the things that's always concerned me is proficiency-based progression is a paradigm that's got clear steps of the development of the metric, the validation of the metrics, and then the training of the metrics. The one thing that has never been achieved, I mean, after somebody gets trained to the proficiency in the clinical situation, there's then the development of wisdom. And I certainly have never been able to achieve or get to the point where I could go about training the wisdom. Because for the PBP, we're training them to do a standardised approach on a fairly straightforward case. The surgical community, the other procedure-based systems, they need more complex. You've got to build it. Have you any ideas about how one would go about helping clinicians acquire the wisdom within the PBP paradigm?
So just to explain maybe for the people who are listening or watching is that so you have different steps up on the learning curve. When you do your learning curve, you can get to proficiency. This can be done according to the standard apprenticeship model, or this can be done according to the PBP methodology. It will take you longer if you do it according to the apprenticeship model, but you can get to a certain level, which is called proficiency. Proficiency for me means that someone is able to perform a standard procedure in a safe way. Will he be expert at that procedure? No, not yet, because the next step in training, meaning going from proficiency to a higher level of surgical expertise, that's going to wisdom. And for me, what is wisdom? That's quite far up the learning curve still, because once you're proficient, once you're safe at a certain procedure, you will need to have, I think, first of all, volume. Like a pilot needs to show that every year he has a certain amount of flight hours, minimum amount of flight hours. So you need volume, because volume is only one indicator for quality. It's not the only, as a lot of people say. But you need the volume to continue improve your skills. And what also defines, so I think that expertise by experience is one part of wisdom. But another part of wisdom, in my opinion, is the ability to deal in a safe way with unexpected or very complex situations during certain procedures. I, Again, I will give the example. I was proctoring a guy. He is not proficient yet at a radical prostatectomy, but he is the only surgeon at the hospital. And so he told me that he will need about 10, 20 cases to independently start. I told him, you're crazy. Because if you are you're maybe able to safely perform a standard prostatectomy, but the day will come that you will have extremely difficult prostatectomy with a heavy bleeding or extremely challenging tissues. And then you will not be able to deal with that procedure, and you will have to stop the procedure. And hopefully you will be able to do that before you have done something wrong, because this demands wisdom. And so wisdom you can achieve by having someone in your back. I was able to achieve wisdom because I had extremely experienced surgeons in working in the same department. Why and like this, I could actually grow quite fast from proficiency towards wisdom and tackling extremely challenging procedures in a safe way. Because I knew at a certain point when I got into problem, I have someone who can help me. So this gives you a safe feeling. And then last but not least, I think it's extremely important if you want to grow towards wisdom to have good examples. So we founded SurgeQuest. It's a digital learning platform. And this is a clear overview of experts, global experts, showing not only standard procedures, but also very, very challenging procedures or very challenging types of certain procedures. And so by knowing how to tackle, or by seeing how to tackle extremely difficult types of procedures, you will also know how to do this. I'll finish with an example. About 4 years ago, I had to do a standard radical nephrectomy on the right side. This was a dialysis patient, had a big tumor on the right kidney, and he had a low quality CT scan. It was a PET scan, and for me, basically, this was enough to actually just do the nephrectomy. But I get into the abdomen, and I notice that the renal vein is very much dilated, and so I do an ultrasound, and I see that this patient has an IVC thrombus, so a thrombus going into the inferior vena cava, which of course makes that you make a transition from a very from a procedure which is very low complex, just a radical nephrectomy, towards a highly complex procedure where you have to completely dissect the IVC, have to clamp him, have to do an IVC thrombectomy. I was able to do that because I attended a lot of conferences before, and I see some Chinese surgeons during ERAS years ago how to do these kind of procedures. And I remembered it, and I said like, okay, I will prepare myself. I will have a cardiovascular surgeon having standby, and I finished the case very smoothly. And that actually driven me to make these examples available for the whole surgical community. So in SurgeQuest, you will find a database of more than 300 high-level surgical videos, which you can use at the moment itself when you get into problems to tackle certain complications. And I think that defines wisdom, that you're feeling safe at any given point, and that if I run into a complication, I will be able to manage it. And this also gives you wings when you do surgical training, because you can give access to the robotic console to your fellows very easily, because if they make a mistake, you will be able to repair it. And this is wisdom, in my opinion.
Yeah, yeah, but I think the SurgeQuest platform that you lead, I think that's the best example that I've encountered so far that helps when somebody trains to proficiency. They've got the foundations and they've got the basic building blocks, but they then need the exposure, and a lot of the exposure they're not going to get in their own hospital, or maybe sometimes not that often in their career, but they need to see it. And if they're trained to proficiency and they know what the indicators are of good and bad performance, if they're exposed to good surgeons doing more complex cases, I think that's how you help them acquire wisdom. So I think what you're doing is very powerful, and it's certainly what I had envisaged. I mean, not the SurgeQuest platform, but certainly some facility like that that would help the surgical community acquire that information that underpins and builds wisdom. Thank you, Ruben.
Thank you, Tony.
So thank you, Ruben, for coming on to the Show Me the Evidence podcast. I'm sure it's appreciated by our viewers, the experience that you've imparted here today and your views on a more scientific and evidence-based approach to surgical training.